Hello everyone, the doctor is in, and for today's lecture video, we're going to talk about ectopic pregnancy. And when we talk about ectopic pregnancy, it means implantation of the products of conception outside the uterine cavity. So normally, the implantation of these products should occur within the uterus. Now, when we talk about ectopic pregnancy, one of the most important things that you should know is what is the most common location of ectopic pregnancy. This question is a very simple question, but it is being asked even in the medical board examination. So you really have to know what is the most common site of ectopic pregnancy. And the answer to that is the fallopian tube. So in the fallopian tube, it occurs in about 95 to 96%. So this is the fallopian tube. This is where your ectopic pregnancy is most commonly located. And when we talk about the fallopian tube, there are different parts of the fallopian tube. So let's have a quick review on the different parts of the fallopian tube. The most proximal portion, we call that the interstitial or the cornual portion. It is the part that is directly connected to the uterus. So in here, there is a 2 to 3% chance of having an ectopic pregnancy. In the second half of the fallopian tube, which is the isthmic portion, it comprises of about 12% of ectopic pregnancy. And remember, since this portion is one of the smallest portion in terms of its caliber, this is where the rupture of the fallopian tube also usually occurs within the first week of ectopic pregnancy. And the third portion of the fallopian tube, we call this the ampulla, or the ampullary portion. This is where majority of the ectopic pregnancy occurs in the fallopian tube. So why is this? Why is this the most common site in the fallopian tube? Because this is the area of your fertilization. So once the egg is fertilized, and if there is a restriction on this portion of the fallopian tube, then the zygote will eventually implant in that part of the fallopian tube. So it's the most common. So if we answer that the fallopian tube is the most common location of the ectopic pregnancy, and it will be further asked what is the most specific part of the fallopian tube with which where ectopic pregnancy commonly occurs, the answer is ampullary. Now, the last portion or the most distal portion of the fallopian tube is called the fimbria. This is where we see finger-like projections. So there are about 11% of ectopic pregnancy that occurs in the fimbrial portion. Okay, so that's it for the fallopian tube. Now, there are still other parts of where ectopic pregnancy can occur. So we also have an ovarian ectopic pregnancy that is about 3%. Okay, it can occur in the left or in the right ovary. So another is the cervical ectopic pregnancy. So we have here the uterus. The cervix is a part of the uterus, but it is the lowermost portion of the uterus. And when ectopic pregnancy occurs here, it will cause a lot of bleeding. So about 1% of ectopic pregnancy occurs in the cervix. We also have in cesarean scar. So if a mother had previously a cesarean section, an ectopic pregnancy can also occur in the scar. And of course, another type of ectopic pregnancy is what we call the abdominal ectopic pregnancy. So in here, this is one of the types of ectopic pregnancy that can be brought up to term. So rarely there are chances that the fetus may live until term. So those are really an exemption na pwede silang mabuhay hanggang term, even though they are ectopic pregnancy. And this can only occur in an abdominal ectopic pregnancy. So I hope it's clear. Where is the most common location of ectopic pregnancy? The answer is the fallopian tube. And if we are asked what most common part of the fallopian tube, the answer is the ampulla. All right. The next thing that you would want to know is what are the risk factors? What may cause an ectopic pregnancy? And the first one, class, is what we call your prior ectopic pregnancy, which gives you another 25% chance to have another ectopic pregnancy. So this is the sad part, class. I have seen women who are devastated because of this. So their first pregnancy came out to be an ectopic pregnancy. So they had to have their fallopian tube removed because of that ectopic pregnancy. Now, next time, they again learn it's another ectopic pregnancy. Why? Because having a prior ectopic pregnancy gives you 25% chance that in your next pregnancy, you will have an ectopic pregnancy again. So you really have to be careful. Another is post-salpingectomy, which gives you 15 to 25% chance of having another ectopic pregnancy. Let's try to dissect the word. If you see the suffix ectomy, this means removal. If you see the root word salpinx or salpingo, it means the fallopian tube. So salpingectomy, when combined together, which will mean removal of the fallopian tube. And when you see post, it means it has already been done. So the surgery was already done. So the removal of the fallopian tube. So if one of your fallopian tubes were removed, then you will have another risk of having an ectopic pregnancy. We also have what we call your post-reversal of sterilization. So for example, you already had your tubes ligated, cut or tied or put into a knot. And if you requested or if you had underwent a surgery to reverse it, then it may become successful, but it may lead 4% may lead to ectopic pregnancy. Another is clomiphene. Clomiphene is a non-steroidal fertility drug. This is being given for women who have difficulty getting pregnant. So this will cause the body of the woman to produce hormones that will lead in ovulation. So that is clomiphene. So this drug may also lead to multiple pregnancies, so twins, triplets, and the like. But the thing is, it can give you a 1.3% chance of having an ectopic pregnancy. Another is the use of our intrauterine device, whether that is a copper IUD or a progesterone IUD. They are both intrauterine devices, but just made of different components. So it will also give you risk factor. And another risk factor would be pelvic organ prolapse. We will discuss this in another lecture video where the organ, specifically most specifically the uterus, is prolapsed, so it may lead to ectopic pregnancy. So these are the risk factors. Now, we'd like to know more. What are the other factors? So you want to ask that question because later on, if one of your patients experiences this one and they will be asking you what may have caused this, so these are the possible answers. Another would be a prior tubal infection or sexually transmitted disease, especially that of chlamydia. So if a woman has had history of tubal infection or a sexually transmitted infection that may have led to an ascending infection, then you may develop ectopic pregnancy. Why? Because if this portion will be inflamed, it may cause scarring, and scarring will cause the caliber of the tube to become smaller in diameter. Therefore, a fertilized egg cell or a zygote may have more difficulty passing through that adhesion or scar. Another of the risk factors would be smoking. So there is a correlation between a smoker and that of ectopic pregnancy as well. And endometriosis. So when we say endometrium, remember, this is the innermost lining of the uterus. So followed by the myometrium and the perimetrium. So when you say endometriosis, class, this is the implantation or growth of the endometrial tissue outside the uterus. So for example, there might be endometrial tissue in the fallopian tube or in the ovary or in the fallopian tube. So we call that endometriosis. And if a woman has this, she may also develop ectopic pregnancy. Now, Another thing that you would want to know, what are the signs and symptoms? Because sometimes you don't know that this is already an emergency. Remember, ectopic pregnancy is an emergency situation. So, we have to understand what are the symptoms. Anong gusto mong hanapin? What would you like to see in your patient? So, the classic triad, my mnemonic is DBP. So, when I put this, a hashtag and some letters, this is usually a mnemonic for me. So, D stands for delayed menstruation or amenorrhea, meaning the woman missed her menses. So, that might mean she's pregnant. Okay, this is, letter B stands for bleeding or vaginal spotting. So this is another symptom of ectopic pregnancy. The woman is bleeding. And of course, another symptom is pain. This is very, very severe pain. Now, aside from this classic triad, you know that the woman might be pregnant because of amenorrhea, there is bleeding, and there is pain. Aside from this, you would want to know what are the different signs of rupture. So, an ectopic pregnancy may rupture, and this is an emergency because a mother may bleed to death. So first, we call that your cervical motion tenderness, meaning if you perform an internal examination and you are trying to assess the cervix. For example, this is the cervix. Once you touch the cervix or you move it, there is motion, the mother will be in pain. So there is cervical motion tenderness. When you touch or you move the cervix, it is tender or painful. That is a possible sign of ruptured ectopic pregnancy. Another is hypotension and bradycardia. You assess the blood pressure of the mother, and the mother is now becoming hypotensive. And the heart rate is slow. So you may think of internal bleeding. Even if it's not evident, you think of internal bleeding. Next, we have bulging of the posterior fornix. So later, we'll be showing you coldocentesis, where you will be able to appreciate the bulging of the posterior fornix. So the posterior fornix is located at the posterior portion of the uterus, specifically on the lowermost portion in the cervix. Okay, so those are the different classic triad and the signs of rupture that you would have to know. Another thing that I want you to remember is, because I had this one patient in the emergency room before when I was having my duty, her main complaint is shoulder pain. She cannot lie down. When I asked her to lie down because I want to make an internal examination, she doesn't want to because she is in so much pain, especially in her shoulder. Ang sakit po ng shoulders ko. So she doesn't want to lie down. Now that is also a sign of possible rupture. Okay. Now for diagnosis, as a feature doctor, a nurse, or a midwife, you have to know what are the different tests that you need in order for you to be able to diagnose ectopic pregnancy. So we have a laboratory test called beta human chorionic gonadotropin. So in our past lecture, if you remember, yung HCG, this is also the hormone that we test in pregnancy test kits. If you have already seen the pregnancy test kits with 2 lines, it means if there are 2 lines, your human chorionic gonadotropin hormones are high, or your HCG level is high. Now, if the PT is at 10 to 20 milli-international units per ml, okay, discriminatory level is at 1,500 milli-international units per ml for you to be able to say that it is an ectopic pregnancy. So you will have to perform a serum beta HCG, meaning the specimen that you will take from the mother is blood. Another is serum progesterone. If we can see in here, if the level is 10 to 25 nanogram per ml, this is the usual level in ectopic pregnancy. If it exceeds greater than 25 nanogram per ml, this excludes ectopic pregnancy, meaning we rule out ectopic pregnancy. Okay, these are the laboratory tests. Now, when we talk about ultrasound or sonography class, we have transvaginal ultrasound. So when we talk about transvaginal ultrasound, the probe is inserted inside the vagina, and this is usually used in the early portion of pregnancy. So we have at 4.5 to 5 weeks age of gestation, we can we are now able to see a gestational sac. So meaning if a woman is at 5 weeks age of gestation or pregnant and we don't see a gestational sac, we can consider that's a possible ectopic pregnancy. Or at 5 to 6 weeks, you cannot still see a yolk sac or a fetal pulse with fetal heart tone at 5.5 to 6 weeks, then you think of ectopic pregnancy. Because supposed to be, you will be able to assess this at this time already. For a transabdominal ultrasound, you can only recognize uterine pregnancy at 28 days after the time of ovulation or 5 to 6 menstrual weeks. So you have to take note of that. Now, here, another thing that you will look for in an ultrasound is the trilaminar pattern on transvaginal ultrasounds. As you can see here, this shows us the trilaminar pattern of transvaginal ultrasound. It demonstrates the trilaminar appearance of the endometrium in the late proliferative phase of the cycle. So the basal layer of the endometrium is echogenic, but more superficial functional layer has become hypoechoic as a result of estrogen effect. So this represents the interface where the endometrium lining and the anterior and posterior walls of the uterine cavity meet. So if you see this trilaminar pattern class, this is usually seen in ectopic pregnancy. So what are the other things that we should consider when talking about ectopic pregnancy class? If there is positive human chorionic gonadotropin hormone, but there is no obvious uterine pregnancy seen on ultrasound, as well as if there is a fluid in the cul-de-sac, we will consider ectopic pregnancy. And the presence of abdominopelvic mass associated with a trilaminar pattern on transvaginal ultrasound. Okay, so in the next slide, here, another way to diagnose ectopic pregnancy is what we call kuldocentesis. When you see the suffix centesis, remember, class, this means aspiration. Aspiration. Kuldo, it pertains to the cul-de-sac or the posterior fornix. So we call this aspiration in the cul-de-sac or kuldocentesis. Now, if the fluid does not clot, we consider ectopic pregnancy. Why? Because, class, if there is excessive bleeding or continuous bleeding from a ruptured ectopic pregnancy, it will not allow the blood to clot because of the continuous movement or continuous bleeding that is occurring. So just to give you an idea what kuldocentesis mean, I haven't been able to perform one like this, but I was shown by one of our consultants, OB-Gyne consultants. So we have here lidocaine with epinephrine, uterine cervical tenaculum, a bivalve vaginal speculum, a ring forceps, and then a 19-gauge butterfly needle and an 18-gauge spinal needle. So as you can see here, class, to review your anatomy, this is the vaginal canal, this is the cervix, this is the uterus, this is your urinary bladder, and at the posterior portion is your anus. So here, we can see the use of the vaginal speculum in order for us to show clearly the posterior fornix. So this is the cervix, class, and located at the posterior of the cervix is the posterior fornix or the cul-de-sac. Here is the accumulation of fluid. Normally, no fluid is located in here. So if there is bleeding, it will accumulate on the posterior portion. It will pull on the posterior portion and it will cause bulging of the posterior fornix. So what you're going to do is, using the uterine cervical tenaculum, you are going to lift up the posterior cervix, posterior lip of the cervix in order for you to be able to aspirate fluid in the posterior fornix. So if the fluid does not clot, then we consider ectopic pregnancy. Okay? So here, for our multimodality diagnosis, meaning we're going to combine different diagnostic tests. So we have transvaginal ultrasound. If we do not see any fetal pole or gestational sac or yolk sac in a transvaginal ultrasound, then we consider, and it is associated with a serum beta HCG that is elevated. It means the woman might be pregnant, but there is no intrauterine pregnancy. Associated with a serum progesterone at a certain level, and performing uterine curettage, and there are no fetal conception, or a laparoscopy or a laparotomy. So this is a multi-modality diagnosis wherein we try to diagnose for an ectopic pregnancy. Now, another thing that we need to learn about this is how are we going to treat an ectopic pregnancy? So there are two ways. It's not only surgery, but it could also be medically managed as well. First, let's talk about surgical management. So there are three different terms here that we would like you to understand. First is salpingostomy. As I've mentioned earlier, if you see the root word salpinx, it means fallopian tube. So these three terms pertain to a surgical management done in the fallopian tube, but it's different. This is ostomy, otomy, and ectomy. So when you see the suffix ostomy, it means we create a linear incision at the antimesenteric border, but we are not going to suture it after. It will heal by secondary intention, ostomy. You're going to incise, but you're not going to suture it. Next is salpingotomy. It is same as above. We're going to create a linear incision at the antimesenteric border, but after which we are going to suture it. So that is salpingotomy. And salpingectomy, remember, what did I tell you earlier? When you see the suffix ectomy, it means removal. So the fallopian tube will be resected. So the outer 1/3 of the interstitial portion, okay, will be removed. So this is what we call a salpingectomy. Now remember, class, when performing salpingectomy, always make sure that you are able to visualize both fallopian tubes first, because what happens is, if the affected fallopian tube is the left, the right fallopian tube usually manifest, or the contralateral fallopian tube usually manifests with a hematosalpinx. And sometimes, if we mistake this as the pathology, the hematosalpinx as the pathology, and we were already able to remove the right fallopian tube, but realize that the ectopic pregnancy is actually in the left fallopian tube, then that will destroy your career and the life of your patient. So always make sure to visualize both fallopian tubes in order to know where the pathology is located. Okay? So here, we also discuss the medical management. It means that it's not just surgery, but we can also do medical management. But of course, we have to take note how we're going to use it. So we have what we call the drug methotrexate, which is a folic acid antagonist. This is also a chemotherapeutic drug. Now, it is contraindicated in patients who are already having abdominal hemorrhage, because when you have abdominal hemorrhage, that means you need to perform surgical management. Those with intrauterine pregnancy, methotrexate will not be allowed to use. Those who are breastfeeding, those with immunodeficiency, chronic renal disease and hepatic disease, or chronic pulmonary disease, blood dyscrasia, and peptic ulcer disease. Now, what are the predictors of success of methotrexate? How do we know that it is working? So first is, you have to take note, class, that you have to have an initial beta HCG, because this is the best prognostic indicator of a successful treatment. Meaning, if for example, the beta HCG remains to be greater than 10,000 milli-international units per ml, then that means we have a high failure rate. We are not able to treat medically the ectopic pregnancy. But if, for example, it decreased, the beta HCG decreased to a level of less than 1,000 milli-international unit per ml, then the failure rate also decreases at 1.5%. Okay, another indicator of success or predictor of success is the size of the ectopic pregnancy. If the size is less than 3.5 centimeter, then it will give us 93% of success rate. While if it is greater than 3.5%, the success rate goes down to only 87 to 90%. And fetal cardiac activity is associated with increased failure rate. And of course, class, if there is a fetal cardiac activity, we should not be using methotrexate, because the baby is still having his or her heartbeat. Now, the following are the side effects of methotrexate: liver toxicity, Yan. Stomatitis, meaning there is inflammation of the mucosa of the mouth and the lips. Gastroenteritis, inflammation of the GI tract. And myelosuppression. Since it is a folic acid antagonist and a chemotherapeutic agent, it causes myelosuppression. And take note, class, we can only perform expectant management in tubal pregnancy only. For example, if you have ovarian pregnancy or cervical pregnancy or abdominal pregnancy, this expectant management cannot be done, or medical management. So if there is only low serum beta HCG, or the diameter of the ectopic mass is not greater than 3.5, and there is no intra-abdominal hemorrhage or rupture. As I've mentioned earlier, if there is already an intra-abdominal bleeding or rupture, then surgical management should be done already. Okay, so now we are going to discuss the criteria for medical management. I think it's not here, but the patient should be stable and the beta human chorionic gonadotropin is low and should be less than 1,500. And as we've mentioned, the diameter of ectopic mass is not greater than 3.5. And the pregnancy should be less than 6 weeks. And of course, there should be no fetal heartbeat anymore. Okay. So now, for the last portion of our lecture, we are going to discuss different criteria of ectopic pregnancy on ectopic pregnancy in different areas. So for cervical pregnancy, we have what we call your Rubin's criteria. So here is an ultrasound showing us a cervical pregnancy. So this is the portion of the cervix with a C-section scar. This is the uterine body and this is the fetus. So we have here an implantation on the portion of the cervix. So what are the things that we can see if there is a cervical pregnancy? The placenta intimately attaches to the cervix. The endocervical glands are opposite the placental attachment. And the placenta attached below, we have insertion of uterine artery. The placenta are attached below the insertion of the uterine arteries and anterior deflection of bladder to peritoneum. And fetal element not within the corpus or the body of the uterus. So we have a cervical pregnancy. Another criteria is called the Spiegelberg's criteria for ovarian pregnancy. So this is the ovary class and this is the ectopic pregnancy in the portion of the ovary. So the tubes and the fimbriae are normal. So normal ang fallopian tube natin. The gestational sac is connected to the uterus via the ovarian ligament. Okay, this is also called an ovarian pregnancy. Gestational sac occupy the location of the ovary and ovarian tissue on the wall of the gestational sac is seen. So this is an ovarian pregnancy class. Another criteria is the Studiford's criteria for abdominal pregnancy. So this picture shows us a rare case of an abdominal pregnancy class wherein the fetus or the baby survived even if it was an abdominal pregnancy. So in this image, we can see here that the baby is not actually inside the uterus, but it is located on the outer portion. So it is an abdominal ectopic pregnancy. So the criteria is called Studiford's criteria, wherein the tubes and ovaries are normal without signs of past or present pregnancy. There is no retroperitoneal fistula and the pregnancy related to the peritoneal surface and early enough to eliminate secondary implantation. The last criteria is the criteria for heterotrophic pregnancy. This is very interesting class, and I have seen one case on the time that I was having also my duty. So when we say heterotrophic, tropic means location, hetero means different location, meaning we have multiple pregnancy with different location. So the first baby is located inside the uterus while the other one is an ectopic gestation. So it's a heterotrophic pregnancy. So sometimes when we see cases like this, we get excited, but actually it's a sad case because meaning one of the babies will not survive and we are not even sure that the other baby inside the uterus will also survive. So what are the criteria? So fundus is enlarged to age of gestation, of course, because of the pregnancy inside the uterus. Symptoms of pregnancy despite excision of ectopic pregnancy. So for example, the only one that was detected was the ectopic gestation, and after removal, we still see signs of pregnancy. Now we have hemoperitoneum despite termination, and abdominal pain, adnexal mass and tenderness, peritoneal irritation with evidence of intrauterine pregnancy greater than or equal to 8 weeks. So, fortunately, class, the heterotrophic pregnancy that I was able to witness, upon removal of the ectopic pregnancy, the intrauterine pregnancy continued until such time that the mother gave birth to that pregnancy. So, it's a very rare case, but I was fortunate enough to be able to see one case that is a heterotrophic pregnancy. So that ends our lecture on ectopic pregnancy. I hope you were able to take some notes on the most important things, and I hope this will help you in preparation for your exam. So I'm now out, and thank you so much, and please tune in to my channel for other lecture videos. On incompetent cervix. So this is defined by a painless dilation of the cervical os without